we plan.
Say again,
We plan
like
for
what will be
all
the
the
component?
preoperative,
Yes.
perioperative, and post-operative anesthesia planning for induction, monitoring, special equipment needed according to patient assessment.
Okay, okay, fine, very good. Like, what will be the things which you would be doing in the preoperative period?
Preoperative, like we assess patients' past medical history, past surgical, and any special concerns about related to patient special condition.
First of all, yes, first of all, you ask about the patient name, age, sex, occupation,
yes.
Okay, anything personal to that. So that is all demographic. Okay, then you ask about any symptomatology which the patient has. Then you explore that symptomatology, since when that symptomatology started, how it progressed, like related to that symptom. Then you take history about all other systems. Then you ask about past medical history, past surgical history, past anesthetic history. Okay, and then you do some examination, systemic examination. Then you on the basis of history and examination, you chalk out that what are the investigation needed. And then once you do some investigation, the purpose of this history examination and investigation is to chalk out the risk factors. Okay, so risk factors related to cardiovascular system, respiratory system, renal system, hepatobiliary system, urinary system, this one aspiration risk, PONV risk, positioning related risk. So this all information will be related to either the risk factors which you have chalked out, according to the history examination, and some things will be related to the surgery. Okay, so when you talk about surgery, Tayyaba, what aspects of the surgery you should be looking at? Actually, we had discussed this topic before. I'm not sure whether you had listened to this this topic or not. So I would just tell me what aspects of surgery you should be thinking or you should be focusing in your mind.
Yes, sir. Generally, if you are talking about on the journal perspective way, so the time of the type of surgery, whether open or the approach, lies on with the surgeon and talk about the approach, whether he is having the open or the laparoscopic approach, the time which he will be taking for the surgery. The also I will be concerning about the blood loss. Is there any if he is concerned about the blood loss or there is a danger of the blood loss in the surgery, I will be concerning that, and also the time, duration, the technique, and the
you
losses.
have not told the things which are important to us up till now. Any point what you have told it comes after the most important. Then when I will try to recall you, maybe you can tell. Are these things more important than something else more important than these things?
Risk of surgery?
No, risk of surgery we are trying to chalk out. The first thing, when you ask, we are told that we are doing this surgery, the first thing you will be thinking whether this surgery is emergent or urgent
Or elective, yes.
or elective. Emergent and urgent comes almost in the same category, and planned surgery and elective surgery usually comes in the same category, but actually there is a little bit of difference. So Tayyaba, what can you give some example of emergency surgery? No, this is just a second. Shamuna, we are discussing the journal aspects we should be considering when we are planning for anesthesia. So we started with the journal history examination and investigation, and on the basis of that we chalk out the risk factors. Okay, and then on the basis of risk factors we chalk out what are the cardiac risk factor, what are the pulmonary risk factor, what are the renal risk factor, what are the PONV risk factors, what are the aspiration risk, what are the risk related to airway management, what are the risk related to positioning. Okay, So these risks will be categorized into two categories. First category will be related to the patient itself. The second category will be related to the surgery. So instead of patient, I have started with the surgery. So whenever we talk about any surgery, the first thing we should be knowing is whether the surgery is emergent or urgent or planned or elective. Okay. So this is the first question you should be thinking in your mind. Okay. So Tayyaba, can you give examples of
Yes,
emergency surgery? Real
yes,
emergency?
sir.
What are those?
Yes, sir. Sir, sir, this is basically the immediate need of the surgery as a
I'm sorry, by mistake, I mute you. Please unmute yourself. Tayyaba, we are mute. Unmute yourself, please.
okay.
Yes.
Yes, sir. Sir, basically, emergent surgery means immediate threat to someone's life or the patient's life. It should be done within the 30 minutes of the plan. So
Okay.
it could be the cord prolapse. It could be the fetal distress.
Sorry, I will try to correct it here. That you should not label it with the time. Okay, because not all surgeries should be even will give you 30 minutes. Does an emergency surgery will give you emergency cesarean section will give you 30 minutes?
So these are basically the recommendations which I have read somewhere.
No, you're right. Again.
Yes, you're absolutely right.
Okay, so you don't need to tell the minutes, because some surgeries will give you even you have to do it immediately. Just tell me one example. What about peripartum cesarean section? Will you wait for 30 minutes?
No, sir, for 5 minutes.
Isn't that emergency surgery?
Yes, sir, that's emergency.
Thank you very much. Okay, usually the limit is within minutes. Okay, within 59.59 minutes. Okay.
Yes, not in the hours. Yes.
Yes,
within 1 hour.
it should not go towards the
urgent,
hours.
you can wait for hours. Yes, sir.
Yes. So some more example of emergent surgeries.
Abdominal aortic rupture, abdominal aortic aneurysm.
Okay. So emergency cesarean section, which we commonly do. This is a little bit like advanced surgery. So you are right. But I think
cord prolapse. Cord prolapse is bradycardia.
No, like emergency cesarean section for fetal distress. This will be one of the most top-notch indication, or you can say cesarean section. Okay, this is one thing. What others will be? Like, what about firearm?
Firearm, yes, sir.
Okay, you will not let the patient bleed, like blunt or especially this one penetrating injury. Okay, penetrating injury either to thorax or to abdomen or even periphery, because in that you cannot delay for a long time. What about gangrenous hernia? Okay.
Yes, that's emergent.
Okay.
Intestinal obstruction.
Intestinal obstruction in which gangrene is occurring. Okay. Intestinal obstruction can be acute, subacute, or chronic. So it will the topmost will be when there is gangrene. Okay. What about a gangrenous limb? Okay. A gangrenous limb or acute limb compartment syndrome, in which you cannot delay, because if you delay, there will be loss of the limb. Okay. If it's getting towards gangrene. Okay. Just like for example, there is a condition in which there is acute blockade of the main artery of upper limb or lower limb, for example, and there is no supply. If you delay it, you will lose the limb. Okay. So there will be a number of surgeries which you can come in emergent. Next is urgent. So give some common example of urgent surgery. Jamil, you want to add something?
Yes, sir. Actually, the emergency also further classified like emergent, like life-threatening, as Tayyaba told, fetal bradycardia, fetal distress. But the emergency surgery further divided as E1, E2, and E3,
Okay.
E4. Further categorized. E1 is within 1 hour. E2 within 2 hours, E3 within 4 to 6 hours, and E4 within 12 to 24 hours.
Yes, these are, yes, you are right. But okay, fine. Fine. So these will be urgent. So give some example of urgent surgery.
Urgent, I also like acute appendicitis. Also, depends upon the severity of
Number
appendicitis.
two.
And femur neck fracture also.
Any fracture is now no fracture is elective. Mind it. Okay.
Yeah.
All
But
fractures
with
are
the risk of necrosis of femur,
that will be emergent. Okay. That will be emergent. If there is necrosis, that will be emergent. Okay. D, what about, we missed one thing in emergency surgery, that is decompressive craniotomy, burr hole. Okay.
Yes.
If there is significant
directly from ER to OR, if
yes,
there is.
okay. So you see, I am just giving you an idea. I cannot compile all the surgeries, but like this is
to communicate with the surgeon about the urgency of the surgery. Then
yes,
you
that's what we do. That's what we do. Actually, I'm just trying to segregate it. So the first thing was and the other surgeries are some of the example of planned surgery are cholecystectomy. Cholecystectomy is not actually in true sense elective because you cannot delay it for long. You have to do it, but you can plan it for weeks. Okay. So emergent surgery usually, unless you are dividing in E1, E2, E3, E4, this is actually usually not commonly used other than in Saudi Arabia. Because in international standards we are doing. In Pakistan, I don't think so. We are using it frequently, this terminology. Okay. So the cholecystectomy and some of the surgeries, they are planned surgery. You have to do it, but you can plan a little bit. Actually, in real sense, elective surgeries are bariatric surgeries. Elective surgeries are cosmetic surgeries. Elective surgeries are joint replacement surgeries. These are not at all to be done in any less time. You are not required to do them. Okay. So this is categorization on the basis of urgency of surgery. The next categorization is according to risk. Okay. Risk of the surgery. So Zishan, do you know this risk stratification on the basis of high risk, intermediate risk, and low risk surgery?
Yes, sir. The aortic and vascular surgeries are high risk surgeries.
Okay. What else?
Then cardiac surgery.
Cardiac surgery, liver transplant surgery, emergency surgery in elderly patients, vascular surgery, anastomosis. Okay. So total cystectomy, these are high risk surgery. Intermediate risk surgery.
Intermediate risk surgeries in.
Sorry.
Yes, Ishan. Yes. Yes.
Sir, abdominal surgeries.
Abdominal surgery, thoracic surgery. These are
abdominal surgery, thoracic.
These are intermediate risk surgery, body cavities. Okay.
Yes,
and then head and neck surgery. Okay. And low risk surgery, they are superficial surgery, breast surgery.
Superficial surgery is breast surgery.
Actually, inguinal hernia, and drainage.
Minimally invasive.
So TURP, Jamil, is it my low risk surgery or intermediate risk surgery?
Intermediate.
I think it is intermediate. Okay.
Intermediate, sir. Intermediate. Actually, I typed, but it sent later. But it's intermediate.
So
superficial, like cataract is.
And open prostatectomy. Open prostatectomy is
also intermediate.
Intermediate.
They open the abdominal cavity. It's intermediate.
Okay. So, but I will just give an explanation about thyroid surgery. Thyroid surgery is written in low risk surgery, but you can say that because they have studied in that part of world where they are not encountering such big thyroids because they are detected early and managed. So the thyroid which we face should not be in low risk surgery. It should be in intermediate surgery, considering it as head and neck surgery. Okay, because head and neck surgery is considered in intermediate risk.
Intermediate.
Okay, so this is the point of a little bit of clarification. So what else about surgery you should be knowing? Then you can say about the incision, where it's being done, the length of the incision. Okay, then you can ask about, actually I tell you something, that one thing is specifically the risk of surgery according to the this one cardiac risk stratification, the American Heart Association. But there is one thing which you have to tell about the bleeding risk. Okay, so this is a little bit different than the surgical risk stratification. So there is high risk of bleeding or there is low risk of bleeding. Okay, so there is a list for that thing as well. So which surgeries will be at high risk for bleeding?
Thoracic surgery.
Okay, what else?
Vascular surgery.
Placenta preta.
Like obstetric hemorrhage. The surgeries related to obstetric, like this one, placenta previa accreta. This is intermediate risk surgery. Okay, but according to bleeding risk, it becomes high risk. Okay, so it's you just have to tell it. You can tell or think separately. Okay, and then you have to think about the approach as from where Tayyaba started, open versus laparoscopic. But this will be coming with the positioning. Okay, and then also related to the length of incision and any critical steps in the surgery. So what critical steps you can tell in different surgeries, you should be chalking out in your mind when you are going for Viva, because you should be knowing it. Atik bhai, what are the critical steps in different surgeries which you should be knowing? Just it's an open-ended question. Usually.
Sir, starting from the optimization.
No. I'm asking something else. During the operation, what critical steps are important? Like one step is vagal stimulation by any place, like cervical place, like rectal place, like eye, like abdomen. During laparoscopic surgery, sudden bradycardia can occur. So this is one critical step which you should be thinking in any surgery which are at risk of developing this thing. Okay. Similarly, for example, in laparoscopic surgery, because of pneumoperitoneum or because of the trocar insertion or because of absorption of CO2, this is a critical steps. First critical step in laparoscopic surgery is the insertion of trocar. Second critical step is the creation of pneumoperitoneum. Third critical step is the gradual absorption of the CO2. So similarly, there will be some steps in different surgery, like for example, orthopedic surgery, application of tourniquet and ash mark is a critical step. Okay, there is autotransfusion. Creation of any positioning during any surgery, creation and reversal. This is a critical step. You have to be planning for that step. Okay.
Clamping of any vessels.
Clamping or unclamping and tourniquet. These are almost the same. So you are putting a tourniquet or you are removing a tourniquet. So this will be a point which you should be chalking out when you are telling. Okay. Similarly, like for example, neuromonitoring is a critical step. If a surgeon, there is a surgery in which they are doing neuromonitoring, you have to avoid muscle relaxant. You have to avoid this one, anything which is disturbing the evoke potentials. So this is a critical step. Okay. Then, for example, if any surgery, they are awakening the patient. Before they used to do it for this one spine surgery, scoliosis surgery. Am I right? Orthopedic surgery we started. Actually, I'm trying to cover a number of things. So in orthopedic surgery, one is tourniquet, one is bone cement. Okay, and positioning. There is high risk of fat embolism or
naming, sir.
I'm sorry. fat embolism or pulmonary embolism when they are positioning the patient. Okay. So similarly, when they are putting a clamping, so for example, aortic cross clamping or unclamping, this is a critical step. When they are doing the clamping, there will be some hemodynamic changes. When they open the clamp, there will be some hemodynamic changes. Okay. When they are putting a patient in position, that will be first step. Then the effect of that position, this is the second step. And when they are reversing it, this is the third step. Okay. So whenever you are telling it, you should be thinking in your mind exercise should be done, then you will not forget anything, I guarantee you. Okay. So similarly, what else? If they are doing any other example, I'm short of.
Sir, oculocardic reflex, sir.
We have told bradycardia. Okay, we have told in
Sir,
bradycardia.
Cross clamping during aortic surgery.
We have done it. What else? What else we have talked it?
So cardiac tamponade and the ascites when drains are also ascitic drain and when the
Cardiopulmonary
cardiac
bypass.
tamponade is finished. This is also a critical step in the hemodynamic instability.
Yes. Opening of tamponade. Okay, in whether in thoracic cavity, whether in abdominal cavity, this is a critical step. Okay, and as Zishan told, going the patient on pump and reversing from the pump, this is a critical step. So you can just think that any critical step you will find, maybe you will not find. Okay, so this is one point. This is we are discussing about.
In the PEDS surgery, sir, the placing of intubation, sir, the ETT tube and the right place is very critical, sir.
Yes. This is yes, you are right, but we are discussing at the moment about the surgery. Okay. Yes, you are right that in some surgeries the appropriate placement of the of any tube will be a critical step. Okay. So
especially in shared airways,
as acute thrombocytoma.
Yes. Another release of any hormones at specific manipulation as pheochromocytoma or carcinoid syndrome. Okay, and then
thyroid storm.
I'm sorry.
Cardiac stimulation during thoracotomies or thoracic surgeries.
Yes.
Leading to arrhythmias.
And dislodgement of the tube or blocking of the tube or bleeding related to in ENT surgery. Okay, so these are the some of the things which you should be knowing. Some surgeries you have to avoid nitrous oxide. Some surgeries you have to avoid muscle relaxant. Some surgeries you have to avoid. You have to use TIVA. Some surgeries you have to be vigilant for bradycardia. Some surgeries you have to vigilant for hypotension. So these are the things which you can think when we are discussing about any surgery. So then
when you are doing surgery, the patient who is under septic shock, sir, we should be very careful. Yes.
Yes. Atik bhai, actually you are right, but actually what I am just doing the exercise is not related to the patient condition. We are talking only purely about the surgery. Okay. The one thing he has told about laser. So laser airway fire is a critical step. Okay. Laser airway fire is a critical step. Laser, when they are using, you have to anticipate because airway fire can occur. Venous air embolism, chances of venous air embolism in specific surgeries, it is something which you have to be taking care of. So when they are putting what they do in the
creating the pneumoperitoneum, sir.
No. For pneumoperitoneum, we have discussed craniotomy. When they put the nail, what did you say? What the name of the thing which they put in the?
Sir, the field,
Anyways, the thing which they put in the
Mayfield something, sir, which is very painful, I guess.
Yes. Okay. So this is these are the critical steps. Also, we have to move on. So the some things related to the incision. Okay, because as will be the site of incision and approach, there will be the anesthesia or analgesia. You have to plan accordingly. Okay. So in some exams they have, I remember I was not doing good in that exam. They even asked me what is the incision for What is the name of the incision for Whipple procedure? Okay, so that is rooftop incision. So things like that, it is an open topic. So you have to just think in your mind, surgical risk, surgical urgency, any critical step, duration of the procedure, site of the incision. So this will make your, for that thing, you have to discuss with the surgery. So remember this important point. Okay, so this is one of the most important part when you are planning the perioperative anesthesia care. Now we are going back again to related to history, examination, and investigation. We chalk out what factors, what are the active cardiac conditions. So someone can quickly just tell. I will ask Zishan, what are the active cardiac conditions? What are the major cardiac predictors? Quickly, you have to tell.
So patient having MI within 1 year.
No.
Patient having unstable angina.
Refused. Within one year is not active cardiac condition.
3 months then.
No.
Sir, within 3 months.
No, wrong. You see, this is
1 month, sir.
This is disappointing for me. What is acute MI? Meher, what is acute MI?
Acute MI, sir, MI within 1 month.
What is recent MI?
Within 7 days, sir.
Within 1 week.
Can you just hold? Give me a minute. I have to receive a call, please.
There are major predictors and
resume. Just a second, please. So what was the 60 days? Listen, what are the active cardiac conditions? Again, I am asking this question. This, in some books it's written active cardiac condition, and in some books it's written major cardiac predictors. Okay, what are those?
So it's unstable angina, MI within 1 month. It's decompensated heart failure.
Okay,
and significant arrhythmia or a significant valvular disease.
Okay, so these are the things which you should be knowing at the straight away. Acute or recent MI, unstable angina. What angina will you say it's unstable?
at rest.
Angina at rest.
Or
angina which has changed in severity and duration from the previous.
No, Ravya, this is not. Usually they classify according to Canadian class angina 3 and 4. Okay, 3 and 4 is in active cardiac condition, and 1 and 2 is in clinical risk factors or intermediate predictor. Okay, angina at rest or with minimal activity, that is angina class 3 and 4, Canadian class 3 and 4. Okay, and decompensated heart failure, what will you say? The same thing. It is New York Heart Association class 3 and 4. Actually it's the same, but the name are different. For that one is New York Heart Association class 3 and 4, and for angina it is Canadian class 3 and 4. Okay, and for this one acute MI within 30 days, recent MI within 7 days. What are the significant arrhythmias? Atik bhai, what are the arrhythmias you will say significant?
So, the arrhythmias which makes the patient unstable and making the
name the arrhythmias. This is, you don't need to tell this. What are the arrhythmias which are unstable?
SVT, VT, AF. These are the
all SVT will be all SVT will be unstable.
They can be stable, sir.
So VT, you will say unstable SVT, unstable VT, unstable atrial fibrillation, and actually symptomatic bradycardias. Okay. Yes, Jamil, what's the issue?
No, sorry. Actually, when he told that SVT or AFib, if patient is stable, then it's not
no, that's what I corrected. I corrected it.
Yeah. That's why.
So SVT, you will use the word unstable SVT, unstable VT, this one unstable atrial fibrillation or flutter, and symptomatic bradycardias. Okay, symptomatic bradycardias. These are significant arrhythmias. Okay.
Third degree heart block as well, sir.
Bradyarrhythmias, what are those?
Third degree heart block.
Significant bradyarrhythmias will definitely include third degree heart block.
The block.
Second degree block and third degree block.
Yes. Okay. So there, and then tight aortic stenosis, tight mitral stenosis. Okay. Dr. Humera, pulseless electrical activity is not active cardiac condition. It's cardiac arrest. So this will not be counted here. Okay. Pulseless electrical activity, VFib, or that is not inactive cardiac, and that's not in the list. We are talking about specific about the American Heart Association or European Society guidelines. Okay. Yes, Tayyaba.
Sir, I just want to ask you one thing, that these are, you name something, these are the active cardiac conditions. So we can say that if patient is having these conditions, so he must be going for angiography or the cardiac condition stabilization before going to any planned or the elective surgeries, isn't
Thank
it?
you. Yes.
If they are asking that.
Like, you know, if you are evaluating the patient, okay, if you are evaluating the patient, if you find like your first sense that whenever you are asking any patient, taking any history, you should be focusing on these things. If any of them is there and the surgery is not emergency, you will refer the patient for the stabilization of that risk factor first. Okay, so this is the first filter without seeing anything else. So the first step is this one. The second step, if for example there is no active cardiac condition, then you will go to the second step where you will see the what will you see? Tayyaba, what will be the next step? Atik bhai, what will be the next step?
Actually, we are not understanding your question, sir.
Surgery, what the surgeries emergency or elective? This what you told that if the major predictive. Sorry.
No, Jamil. I
surgery.
will just rephrase. Yes, Dr. Ayman.
Risk of surgery, I think, and then the MET. It's the
yes,
metabolic equivalent of the patient.
Yes, very good. You will be seeing two things actually. You will be seeing low risk surgery and functional class.
High risk surgery, yes.
Okay. If the surgery is low risk, and you don't have any active cardiac condition, you don't need to do anything else. Okay, you will be doing the surgery. For what is the example for this? Because this question they ask you in the exam, and actually you are not able to, because nobody will ask you this question separately. They will be giving you a scenario, like I give you an example. Patient known case of diabetes mellitus and having gangrenous foot. Will you proceed or will you delay it?
Proceed,
sir.
Okay, so this why? What is the thing? Because there is high risk. Sorry, this is like urgent surgery, emergent surgery. Okay, so you just have to see that there is no active cardiac condition. You have to, even if there is active cardiac condition, in this scenario you cannot delay it. Okay, you will just do, even if the patient is one of the active cardiac condition. Okay, and the surgery is urgent, you have to proceed with high risk stratification. You will be doing aggressive monitoring. You will try to reduce the intraoperative risk factors, but you cannot delay the surgery. Okay, you cannot delay the surgery. The first thing will be this thing. The second step will be that if there is no active cardiac condition, now you will be seeing at the risk of surgery and functional class. If the functional class is what will be the points related to functional class, whether you are able to assess the functional class and or whether you are not able to assess the functional class. For example, there is a old mama who has osteoarthritis. So now you cannot access the Dr. Yusuf, can you mute your mic? Please mute your mic, Dr. Yusuf Hashimi. I'm unable to mute your mic. Please, can you mute your mic? Okay. Okay. So, then the second step is the clinical risk factor or intermediate cardiac predictors. Intermediate predictors. What are those? Who will tell? Raise the hand.
Yes. These are.
Atik bhai ko batane do. Rabia, please let him speak. Yes, Atik bhai, please.
And the intermediate predictors are mild angina, compensated cardiac failure, diabetes mellitus, renal insufficiency, and MI.
No. You have to specify few things. Not all diabetes, only insulin-independent diabetes mellitus. Okay.
Oh.
Renal, not all renal insufficiency. It is renal failure with creatinine more than 2. Okay.
Okay. Okay.
And what about CVA? Old history of CVA.
Old history of CVA.
CVA. Okay.
That come in some minor predictors or
no, it is intermediate predictor. Okay. And it is also called Lee's revised cardiac risk index. Some places you will find clinical risk factors. Okay. So in the start, you said MI, so you have to tell old MI, history of MI, or stable angina like angina class 1 and 2, compensated heart failure like class 1 and 2. Okay.
Okay, sir.
So this thing should be on your tips. There is no exclusion for this thing. Okay. This thing should be on your tips. Active cardiac conditions, intermediate predictor, or the clinical risk factors, because your investigation will be according to them. What investigation you want, or how many investigation, because if there are one or more than 2 clinical risk factors and there is high or intermediate risk surgery, you will do invasive testing. Okay. Because in these, especially in the conditions where you cannot do the functional class, you have to do the invasive, like you have to do what test you will be doing, Tayyaba? Like we say, we are not able to assess the this one functional class. We cannot check what is the cardiopulmonary reserve. So what will you do?
So we can use the coronary perfusion scan for these patients?
The thallium, stress thallium or stress echo. Dobutamine stress echo. Okay. Because that's the only way you can estimate the status. Thallium scan, stress thallium scan, and dobutamine stress echo.
Thallium scan is not stress. Actually, they give the dipyridamole, which is vasodilator, and do the scan. But there is the stress echo with the dobutamine.
I'm sorry. Yes, you are right. Dobutamine stress echo or thallium scan. Okay. I was using technetium. I was using the word stress. Okay.
Sir, kindly repeat it, please. I didn't get it. You told the 2 tests which we can do in those patients in which we cannot assess the functional class.
Yes.
One is the dobutamine stress test, and
echo,
other is
dobutamine
the
stress echo. Dobutamine stress echo
and the thallium.
And stress thallium.
And the thallium.
Jamil, there is one stress thallium as well. Yes. I know. I'm not able to. You are make me confused a little bit.
Actually, sir, the patient who cannot do any, they have the osteoarthritis.
Exertional activity.
Do activity on treadmill. Then go to stress echo. They gradually increase the dose of dobutamine and increase the tachycardia. Then they will assess there is a risk of any ischemia or wall motion abnormality.
No, Jamil, but listen, they give how they do stress thallium. This is a stress thallium you have.
No, stress thallium, sir. Scan they give just only isotope dipyridamole, which can dilate the coronary artery, and then they detect these isotopes molecules. Where there is more isotopes, it's differentiate with the area where is less blood flow and there is less concentration of these isotopes. And
So basically, you're saying that thallium scan is a perfusion scan. It's a type of
Yes,
perfusion scan in which
yes,
we see the
type of
perfusion of the coronary.
Listen,
Yes.
Jameel, there are two components. This is I know it very well, so I was confused. There are two portions. Okay, one is resting portion and one is exercise portion. You will do exercise portion
You are right.
if the because stress thallium is the one by which they see whether there are perfusion defects or no. These are two different things. One is stress, dobutamine stress. Okay, it will
Yeah.
be done for the patient who cannot move. Okay.
Yes.
Patient who cannot move, they will do stress, dobutamine stress echo, and they will find segmental wall motion abnormalities by the stress of dobutamine. Okay, okay, Tayyaba?
Yes, sir. Yes.
Because
Yes, sir. And the second one is yes, sir. And the second one is the thallium scan, right?
thallium
No, I get
scan
it.
whether with or without stress. Okay. So if they want to do if the patient is able to move, they will, because you know what is the rationale of doing thallium scan? The rationale of doing thallium scan is to see whether the coronaries are perfusing a specific area or no. Okay. If the areas of the heart are taking the dye, it means they are perfused. The similar thing is being done by before cardiac surgery. They used to do a cardiac CT. By which directly they see the patency of the vessels. This is also another thing which we commonly don't use. We use this thallium scan. Okay. So one is
yes, sir, you're right.
Okay.
They do into different steps at rest also and after exertion also.
Yes. Okay. So you are clear about it. If the patient is unable to move because of some other disability, and now you cannot assess the functional class, because for functional class it should be more than 4 METs, which is one MET is 3.5 ml per kg per minute. Okay. And for UL surgery, usually we say that if patient is able to do 2 flights of stairs, the METs are more than 4. Okay. And if you are not able to assess, then you have to do the pharmacological stress testing. Okay. And when will you do it? According to the clinical risk factors or intermediate predictors, which Atik Bhai has just told. Okay. So this is the whole of the picture. Then what are the at this point of time, we will also chalk out what are the findings in minimum possible word, Tayyaba. What are the findings? We have done this many times. What are the findings which you will be getting from echo?
Okay. So first of all, the valve area and the valve motion abnormalities, if there are any, the ischemic changes, any valvular pathologies, the valve area, the pressure gradient between these valves, any kind of hypertrophied ventricles, and at the last we can also see the ejection fraction.
Okay, so you have not told in the way. When I will be telling, you will be saying that yes, Dr. Zishan, this is a better way, because this is not answer of your caliber. Okay, again I will repeat. There are one function of the heart is systolic function. One function of heart is the diastolic function. One function of the heart is the doors, which you say valves. One function of the heart is the chamber size and chamber pressure or any clot in the chamber. Another function of the heart you will be seeing through echo is the pulmonary hypertension. And the last but not the least will be vena caval compressibility. Okay. And presence of any line on anything in the heart. Now we will go step by step to systolic. Systolic function will be seen in the form of ejection fraction, and ischemia is sorry, I missed the ischemia. Ischemic function. So ischemic function will be either because of segmental wall motion abnormality. The next step will be hypokinesia. and then next step will be akinesia. Segmental wall motion abnormality, hypokinesia or akinesia. This will be to show the ischemic or infarctive function. For the systolic function, it will be in the form of ejection fraction. You did not mention about diastolic. You are telling about the length or this thing, but it is actually the diastolic relaxation. Okay, the diastolic relaxation, because diastolic relaxation will be telling you how much.
Coronary perfusion.
No. How much heart is compliant? Because if you see the ejection, if you see the report of echo report of a hypertensive patient, the least important, I'm using the word, the least important finding is the ejection fraction. And you are looking at that and you are very happy telling ejection fraction is normal. And this is the least important thing I'm repeating with conviction, that the least important thing to see in a patient with hypertension, if ejection fraction is normal, it is giving you no signal. Yes, if it is low, this is significant. Okay, because ejection fraction, for example, what is ejection fraction? The heart is not compliant. He's angry. He's saying, I am working so hard. So he's stopping to relax because of hypertrophy. Heart is not relaxing now. So before he was receiving 100 ml, now he's receiving 80 ml. So before he was out of 100 ml, he was pushing 70. So you were saying ejection fraction was 70%. Now he is not receiving 100. He is receiving only 80. So out of 80, he is sending 60 even. You are still very happy. The ejection fraction is more than 70%. But is it telling you the real story in the heart? No. Heart is sinking down. And also the E/A ratio, which Bilal Tufail explained to all of us a few weeks ago. Okay, like the normal, in the normal patient or in the patient which is dependent on atrial kick. This will be in the passive filling time, how much blood is coming and how much push is needed from the atria. Because when they are reading it, this is very important. Okay, so this will be telling you the real information from the heart. And regarding the valve, you will be seeing at the valve size, valve pressure gradient, transvalvular pressure gradient, and the regurgitant fraction. So three things, and then the chamber pressures, chamber volume, and any presence of the clot. And the other thing which I told you about the vena cava compressibility. Okay, because if vena cava is compressible, it means patient is fluid deficient. And if there is a hypotensive patient and you do an echo and there is vena cava is already distended, so this patient needs inotrope. This patient doesn't need fluids. This patient, this is an indirect. And the same thing, actually, practically, you are doing it with the leg raising test. Clinically, you are doing it with the leg raising test. If you are raising the leg side a little bit and blood pressure is improved, it means patient is fluid deficient. The same thing, more scientifically, you are seeing it with the echo. So this is the rationale behind it. And you are also seeing the direct telling to you the pulmonary hypertension. But the exact way to check the pulmonary hypertension is through right heart catheterization. Okay, so this is the sequence of events which you can get from the echo. Okay, so we are coming back because we are taking too much time on this thing, but this is very important. You will be asked about echo, and Atiq bhai will tell us what information you can get from ECG.
ECG, sir.
Yes, Atiq bhai, there is some problem. Anyone else?
Yes, sir.
Yes.
Sir, net kharab hai thoda sa.
Okay. Anyone else can take over? Zishan, what information would you like to see from ECG?
So rate, rhythm, STT changes.
Very good.
And then
you know, if you will, whenever you will jump, you will miss. Okay, so there are some
axis deviations.
Axis, rate, rhythm, access, okay? Then you can say ischemia infarction, and then you can say the individual P wave morphology, PR interval, QRS, QT interval, okay? And any electrolyte change abnormalities, okay? So in this, everything will be covered. Any blocks, okay? Any hypertrophy. So in that way, you will not miss anything. So rate, rhythm, access, hypertrophy, ischemia infarction, P wave morphology, PR interval, QT interval, QRS complex, and the electrolyte changes. Okay, so this is how information you will be getting from ECG. What information like we are trying to cover in the because we started from the cardiac risk factors or clinical risk factors, or we were saying that how will you evaluate, because not in every patient you need ECG, not in every patient you need echo, not in every patient you need dobutamine stress echo, not in every patient you need stress thallium. This you will be deciding on the basis of the risk factors you have. Okay, so the another test which you will be needing in specific scenarios will be cardiopulmonary exercise testing, which is, what is it? Who will tell? What is cardiopulmonary exercise testing? Rabia, what is cardiopulmonary exercise testing?
So it is advanced modality to look for the cardiac and respiratory reserves in a patient, in which we see that anaerobic threshold and oxygen consumption in a patient after giving some exercise to the patient.
Like you will just do it by putting the patient on the this what is this machine?
Treadmill, sir.
And you put ECG and you put a mouthpiece where they are measuring the, what they are measuring?
So they're measuring the gases.
Gases as well, PaO2, PCO2, and they are checking the anaerobic threshold. Okay.
Yes.
They are telling you the maximum exercise capacity, a maximum oxygen utilization. Okay.
Yes.
So these are the information which you can get from cardiopulmonary exercise testing. This can be a small component which they can ask you. It is to assess the, like for example, lungs are getting the oxygen, but heart is not able to pump. So that will not make the this will be useless then. Okay. So this is the, usually they are doing it in this one thoracic surgeries, or some other in you are, if you want to do it. There are some other tests, shuttle test or walking test, something like that. You can have a look at that as well. Okay. So
yes.
This is, so now if we finish around cardiac, so now we will go to pulmonary risk factors, because the purpose of history examination and investigation is to chalk out cardiac risk factors, or clinical risk factors, you can say. The purpose is to chalk out pulmonary risk factors, renal risk factors, aspiration risk factors, PONV risk factors, okay, positioning related factors. So now we will be going about the pulmonary risk factors. So Dr. Atik, what are the different pulmonary risk factors?
Sir, pulmonary risk factors are, sir, the shunt hypoxemia, hypoxia, and sir.
Would you like to classify them according to patient related, surgery related, anesthesia related?
Well, first of all, say in the patient related, the patient, sir, can you hear me, sir?
Yes, yes.
In the patient related, maybe the surgery, the patient related means the patient may be having a COPD or asthma, cardiopulmonary reserve already having, and the anesthesia related. I mean, which anesthesia which type of surgery we are doing it, and how much risk involved in that surgery, like pneumonectomy, like mass pneumonectomy, mass removal, and tracheoesophageal fistula, we are doing that. Then we have anesthesia.
Atik bhai, what are the surgeries which are at risk for pulmonary complications? You are distracted. This is not the answer to this question.
Sir, in the pulmonary related, maybe and even laparotomy can cause pulmonary complication.
So you have to say upper abdominal surgery, okay? Thoracic surgery or upper abdominal surgery.
Thoracic surgery, cardiac surgery, maybe cardiothoracic surgery and upper abdominal surgery.
What else?
And sir,
high age, advanced age.
And advanced age, sir.
Age and patient-related factors will be like you told COPD. One of the factor which you have forgotten, very important factor you have to mention is hypoalbuminemia. Okay, decreased albumin, because the albumin is the factor which is keeping the fluid in the vessels. If you don't have the fluid in the vessel, don't have albumin, the fluid will walk out of the vessels and go in the. Okay, so it will create pulmonary edema. So low albumin is a risk factor, high age is a risk factor, okay, or patient already have COPD or things like that. So, and if you are giving too much blood transfusions, is it a pulmonary risk factor? Patient can go in ARDS, patient can have acute lung injury. Okay.
And fluid overload and TACU
and I was about to listen from you, but unfortunately you have not told in patient risk factors. What is the mother of the complications related to pulmonary system, which we have in any corner of the world? Smoking.
Mother of the
smoking. Have you told smoking as a pulmonary risk factors?
Not told.
Okay, so thank you very much. That's what, if you don't classify, you will die. Okay. So this is how you have to focus on the patient. For any, if you want to tell anything. Yes, pregnancy is also a thing. Okay. So patient related, surgery related, and what about anesthesia related? You have not told anything related to anesthesia.
General anesthesia and prolonged
general anesthesia, prolonged anesthesia, drugs which have chances of having respiratory depression. Okay. So things like that. It's very position related. Like so, like in those patients, you will be doing risk stratification by what will you do? Because you have to do, like where there we say that we in cardiac, I forgot to mention one thing, that if there is any risk of cardiac, there are adequate clinical risk factors or cardiac risk factor, you will be doing the risk stratification. You can do pre-optimization, okay? You can have the minimum invasive surgery. You can have the minimum invasive anesthesia. You will be trying to have the minimum stress. You will be giving multimodal analgesia. Okay. You will be having the stress, blunting of the stress response. You will be taking the aggressive monitoring in the form of either an arterial line, or you can take pulmonary artery catheter or cardiac output monitoring according to the scenario. But this thing will be coming in your mind. That when you what next, they will be, you will be telling, I will be taking the history of this thing. Okay, fine. I will be doing examination. Okay, fine. I will be doing this investigation. Okay, fine. What else? The fourth step you are not able to tell. So whatever you are doing, the purpose is you are doing to do something. Otherwise, you are not taking, you are not doing a geo news interview. Okay, you are not doing any interview on a news channel. You are asking the question for some reason. So the reason is on the basis of history, examination, and investigation, you are chalking the risk factors, and then you have to anticipate. If there is cold weather outside, you have to wear more warm clothes. You have to put a cap, you have to wear the socks, you have to wear a big jacket. That's what the purpose of asking this whole drama. Otherwise, you are not supposed to waste time. Okay, so this is the purpose, that optimization can be in 1 hour, that optimization can be in 1 month, that optimization can be in 1 year, whatever the scenario is. So, but the purpose is to optimize. Okay, so pulmonary optimization, quickly, very quickly, please someone tell. What are the pulmonary optimization? You find that there is high risk surgery for pulmonary problems. So what optimization you can do immediately?
Sir, treating any infection, their incentive spirometry, giving chest physios,
okay,
and breathing exercises,
okay,
and improving the nutrition in the form of improving albumin level and
okay.
hydration. And on the surgical side,
No, just a second,
minimum.
just a second. You have become friend of Atik Bhai. You have not mentioned smoking.
Yes, sir, stopping the smoking, and also postural drainage.
Are you
So-
are you also in Skardu?
No, I'm not.
Okay, okay.
No.
So factors like minimum. We just discussed minimal invasive surgery,
Yes.
minimum invasive anesthesia.
Try to avoid general anesthesia and giving regional anesthesia, multimodal anesthesia post-operatively for doing better
Avoid what is the main factor which you have to avoid post-operatively to have decreased complication?
It's pain.
pain,
and splinting. Okay.
to avoid splinting. Yes.
Some people think that we don't have to give opioids. If you don't give opioid, patient will be screaming and crying and not able to breathe, and you will make the patient die. Okay, so you have to give opioids. You have to titrate in a way that you are achieving the goal in a better way. Whatever technique you are using, you have to be careful about it. If you give epidural or spinal, they can have also problems. So you have to do the risk versus benefit. Like in patients of COPD, they are at high risk. COPD in spinal is not safe. The epidural is not safe. GA is not safe. So you have to choose a lesser devil, because all of them are devil for that miskin patient. Okay, so you have to choose which devil, or you just have to tame that devil. Okay, like you, if you are giving, you can have a combination of GA with the epidural for better post-operative outcome. Maybe this may be a reason. You are avoiding decreasing. There are in COPD patient, there are chances of patient going in in addition to whatever we are discussing, there are chances of thromboembolism. In this patient is at high risk. So if you are giving epidural, this you are reducing that chance. Okay, if you are not giving very high concentrated solution of local anesthetic, which is required for surgical anesthesia, if you are using it only for post-operative pain, that will be helping you. Okay, so that is what is called an anesthesia planning. You are trying to avoid the histamine releasing drugs. You are trying to use irritants. Okay, you are just trying to have you can use post-operative CPAP. You can use post-operative postural drainage, or even you can do the same things before. You can this one. If the patient is having ascites for any good reason, you can drain it. It will improve the post-operative outcome. As we discussed, you have to stop the smoking. You have to maintain the albumin levels. So that's how what will be the result of actually cardiac and pulmonary both. You can, some of the things will be the same. Okay, treatment.
So we will divide
yes, you can divide it, of course, divide it into, usually majority of things will be pre-operative. Majority of the things, even we have not mentioned the arrangement of ICU. Okay, this will be one of the things which you have to plan when you have somebody have told the patient is having COPD and you are having an open laparotomy. Okay, so immediately it will flash in your mind that this patient might need post-operative ICU. Because even if you are able to extubate the patient, this patient might need more strict monitoring. Okay, so this is how you plan. Again, I'm repeating the same word so that it is imprinted in your mind. And mind it, we are not discussing any specific disease, or we are not discussing a specific surgery. These are the things which you should be telling in every patient, and I guarantee if you tell these things, you will never fail in any scenario, because that's for what we are doing any anesthesia. Okay. So preoperative, intraoperative, and postoperative you can say, but majority, I am again repeating, majority of the things are preoperative, like incentive spirometry, just postural drainage. You have to start it in preoperative period and you will continue it in postoperative period. Okay. The smoking cessation, you have to start it according to the risk and according to the type of the surgery. Treatment of heart failure, you have to do it before by diuretics or vasodilators, okay, or inotropes. And then like these are the things which are actually combined. Treating pulmonary hypertension if you can, okay, or because this will improve the post-operative outcome. Okay, so I have given you a hint, and there are so many things which you can elaborate from there. First of all, you can classify in two ways: preoperative, intraoperative, and postoperative, but try not to overdo, because if you try to divide it, you will be confused. It is just not, it is just for your help not to forget. It is not the way that it is mandatory for the examiner to listen, because sometimes people are being forced to do this under threat and they are not able to explain it in a proper way. Yeah, they will forget it. So this is to make sure you don't forget, rather than you are just hitting your own feet with something sharp. Okay, so this is just for helping. And the other thing will be anesthesia related, surgery related, and patient related. So in this way you will be focusing and targeting the things. So now come the next major organ will be renal. Okay, so how will you chalk out the Zishan, would you like to say what are the perioperative renal risk factors, renal risk factors?
Sir, acute renal shutdown एक क्या है sir?
Atiq bhai, you have not understand my question. What are the perioperative renal risk factors? Again,
Sir, first of all, it's fluid status.
Again, you can divide it into patient related, anesthesia related, and surgery related. Why don't you do like that in your mind? Even, for example, just for practice, well, you started with fluid status. Okay, fine. What else?
Electrolytes.
Okay, this you are jumping to the intraoperative actually. Patient related factors, if you want to tell, just think about diabetes, hypertension, patient patient on steroids, patient on NSAIDs. These are the patients who are at risk for perioperative renal dysfunction. Am I right?
Already having renal insufficiency.
Renal already baseline renal, but it will be related to some of them usually. Okay.
Yes.
So diabetes, hypertension, steroids, NSAIDs. Okay. Okay, Atiq bhai.
Sir, if we can say the drugs, only drugs we can name, then we can make it easy. Walter
Yes.
from
It's not only drugs, there are many factors other
There are
than
many
drugs.
factors other than drugs. Okay. Oh, okay. Now, if we come to the anesthetic factors, what are the anesthetic factors, Atiq bhai?
Anesthetic factors are sir, hypotensive anesthesia.
Okay.
And sir, the anesthesia which are very prolonged and
Okay.
like aortic.
This is surgery, please. This you can tell in surgery. What else? You tell hypotension. What else? Hypovolemia. When you are telling about hypotension, the other important thing, or it's simultaneously hypotension, hypovolemia. Okay.
Yes,
because if there is less volume, even if there is tension, if you are increasing, it's the same, like it will have even more detrimental effect. So hypotension, hypovolemia. What else?
Sir,
So blood transfusions, the use of vasoconstrictors.
anemia, thrombocytopenia, blood transfusion, sir.
Acid-base balance.
Acid-base balance.
Okay, how
the drug we
anemia?
use that secreted by kidney.
What's that, Dr. Ayman? Sorry?
Any drug we use that depend on excretion by kidney.
No, no. Actually, we are cross-sectionally seeing what are the things which can damage kidney. So hypotension, hypovolemia, use of NSAIDs, and there are certain other things which can damage kidney. What are those?
Sometimes
Hypoxia.
we use nephrotoxic drugs like dyes or something.
Yes, dyes. Use of dyes, contrast dyes. Okay, Atik bhai, you understand?
Yes, yes,
Sir.
sir. Yes, yes.
So use of dyes,
Use of dyes and sir, fluid overload as well, sir.
Fluid overload will, okay, Atik bhai, why you want to make the list prolonged? Have you ever seen acute renal failure with fluid overload?
It can complicate the things, sir.
No, please, Atik bhai, it's unwanted. Please don't. This actually you cannot defend in the exam. How will you defend? Okay, please explain to me. How will it complicate?
Sir, if there is fluid overload, why we do dialysis then?
No, that is something else, because heart is not able to work. We are talking about the things which can damage the kidneys in perioperative period. How fluid overload will damage kidneys. You understand?
That time heart cannot manage and the pulmonary edema developed. Then they do the immediately dialysis.
You understand? You are right. When there is fluid overload, we do dialysis. But this is not the point which I am asking at the moment. We are discussing about the factors which can cause perioperative renal dysfunction. Okay, so we said that there are some patients at risk who have some diseases like diabetes, hypertension, patient on steroids, patient on NSAIDs, patient on rheumatoid drugs, or any nephrotoxic drugs patient was taking. This is one thing. Then we said that if you are giving hypotension or hypotensive anesthesia, patient is hypovolemia, patient is hypoxic. And if we are using contrast dyes or patient, one thing we can put it in any place is any trauma or anything in which there was this rhabdomyolysis and now the myoglobin is damaging the kidneys, or anything which is damaging the kidneys. So you can put it either in patient factors or the anesthesia related factors. And then will be
using of sevoflurane.
Use of sevoflurane actually
with low flow.
Low flow, actually this is not clinically proven, but yes, it can be one of the thing you can tell, but actually this is not clinically proven. Okay. And then
hypoalbuminemia, sir.
Hypoalbuminemia, how will it damage kidneys?
Because of the increased drug secretion, sir.
Then what will happen?
It will cause damage. Then the drug will not secrete it. Then it will cause damage to the.
Atik bhai, I also again sorry, with due apologize, I cannot accept this reason. How hypoalbuminemia will damage the kidneys? You are not getting the point.
It's patient factor. It's
Actually,
not
there is
anesthesia factor.
Another mechanism for albumin hold the electrolytes and fluids, in intravascular. When there is low albumin, that means there is low oncotic pressure, and the fluid can go to interstitial tissues, especially in the lung.
Okay.
And it can cause the pulmonary edema.
Yes, this is something else. We are talking about renal risk. Okay, so now the last thing is remaining is the surgeries. What are the surgeries which are specifically at renal risk, Atik bhai? If Atik bhai is an internet problem, but so yes, aortic aneurysm surgery, spine surgery, prolonged surgeries,
prone position surgery also.
Vascular surgery, any surgery.
Increase the abdominal pressure.
There is retraction on the kidneys in the way that the blood flow is impaired. Okay. Or yes, passive bleeding, prolonged surgery. So these
prone
are
position with laparoscopic.
Yes, and when there is chances of development of abdominal compartment syndrome.
Abdominal compartment syndrome.
Surgery needing hypotension, hypotensive anesthesia.
Yeah, we have
or-
discussed this. We have discussed it. So usually these are the things which has more advanced age. Sorry, in the patient factor, advanced age is left, and males are more at risk, at like many other things. Okay. So I think my point was that I hope all of you understand. We are just trying to chalk out the plannings. Okay. So there are some things which occur because of renal failure, the electrolyte and overload and whatever we are talking. This is occurring because of renal failure. We are discussing at the moment in the other way around. Okay. If we are discussing this thing in other way around, that what are the things which can damage kidney. If there is any hypoalbuminemia or anything, it can worsen the situation because of extravasation of fluid, but this is not the factor for renal dysfunction. Okay, so it occurs in renal dysfunction rather than it is causing renal dysfunction. So what will we do now? What will we plan? Good volume, good perfusion pressures, like higher perfusion pressures, avoidance of the drugs which can cause renal dysfunction. Okay, so this will be the end.
That use of vasoconstrictors also can damage the kidneys, and blood transfusions, multiple transfusions can also
Yeah, you can avoid as much as possible. Okay, then you can use N-acetylcysteine, Atik Bhai's favorite phenol-dopam. Okay, so these are the medicines which you can use for the. And what about during a clamp, aortic clamp, what you can do? Bypass. Okay, you can have a bypass, or the surgeons can manipulate the position of the clamp in the way that they are trying to spare the renal artery if possible. Okay, but these are the things which you can do. What about mannitol? Mannitol can also be used. Mannitol or diuretics themselves can cause, but actually the volume, the pressure, the avoidance of the drugs, avoidance of ischemia, avoidance of hypoxia, these are the things which you have to anticipate. So we talked about respiratory system, we talked about cardiac system, pulmonary. Now some other things. What are the risk factors for post-operative nausea, vomiting?
So again, we will divide it into patient factor, anesthesia factors, and surgical factors. So patients, females are more prone, and childs are more prone, and also patient having previous history of post-op nausea, vomiting, patient having history of motion sickness, and also dehydrated patient, patient
chemotherapy.
with chemotherapy, and also non-smokers are considered having more risk of post-operative nausea, vomiting.
Okay.
And anesthesia related risk factors are all the volatiles, opioids, nitrous oxide, and
Neostigmine, hypovolemia,
hypoglycemia,
okay.
and electrolyte imbalance, and also regarding the surgeries, there are many surgeries: head and neck surgery, eye surgery, ENT surgery. These are
any surgery there is vagal stimulation,
any intra-abdominal surgery with vagal stimulation,
laparoscopic surgery, middle ear, any surgery with the balance, association with the balance.
Yes.
So it will be at risk for. So now how these are the risk factors, these are the surgeries, these are the patients, and now what will you do? We will try to have opioid-free anesthesia.
Yes.
You will be trying to use propofol rather than ketamine or etomidate or thiopentone. Okay, you will be trying to use this one. You will try to avoid muscle relaxant so that you don't need to give neostigmine. You will try to avoid nitrous oxide. You will try to
hydrated before less time of the fasting, and also at the time of anesthesia, less abdominal distension by doing less at time of induction,
Yes,
especially.
yes, you
by
are right.
doing less.
And then what else? What else? You will if there are more risk factors, you will be using more than one
Combination.
agent. Ondansetron, metoclopramide,
And
dexamethasone. Okay. And what else?
And
Some
also
antihistaminics. Antihistaminics. Huh?
antihistamic, anticholinergics.
Yes, there are some medications which they are using, and also one medication you have forgotten, which is used for actually not vomiting, for nausea.
That is that is
Also
for motion sickness.
Yes, for motion sickness, that is hyoscine or scopolamine, and
Yes.
for this one, haloperidol. Okay, haloperidol is
Yes.
also being used for post-operative nausea. Okay.
Okay.
In addition to its use in delirium, and then you they can. So this is the mind. Actually, the topic which we are discussing will not be asked in this way. But believe me, I again say again and again that if you know this, if you have make your plan in like this way, I guarantee you will be able to handle any question of scenario based. Okay. So aspiration risk. Who will tell? Zishan, would you like to tell, please? What are the risk factors for aspiration? Or anyone?
Patients having
yes
certain conditions, like patient having GERD,
okay,
obesity, obstetric patient,
okay,
NPO,
emergency
surgery.
Emergency surgery. Okay, like patient factors, you can say in pain. Patient in pain
Okay.
will be at risk of aspiration.
Full stomach patient.
Full stomach patient will be at risk of aspiration. Diabetic patient will be at risk of aspiration. Renal failure patient will be at risk of aspiration. Okay. What else?
Liver disease.
You started with GERD. You see, there's Ishan, that's make the problem. Okay. Actually, you try to tell in the simpler way. Okay. Diabetic patient, pregnant patient should be your first answer. Pregnant patient, full stomach, emergency surgery, like the things like that. Okay. So what surgeries is okay. I from there add on emergency surgery. Which other surgeries are at risk for aspiration, like intestinal obstruction?
Yes.
Pyloric stenosis.
Surgeries in having tendon position.
Yes. Oh, and sorry, I forgot very important thing. All other autonomic problems like GB syndrome, myasthenia gravis. Okay. The patients have any neuromuscular problems. They are at risk of this one, cerebral palsy. They are at risk of more of aspiration. Okay. Old age patients having less bulbar muscle tone. Okay. Parkinson's disease patient. So I only recalled autonomic, so these things came into the mind. Down syndrome, yes. Okay. So this is how you will chalk out the patient related. And again, I repeat, if you are able to memorize it without saying, it is better. If you want to say patient related or surgical related, this is for your help. So don't overdo it again, because I used this word before as well. I'm telling again. So how to avoid it? You will be giving the aspiration prophylaxis. Your target will be to reduce the gastric volume less than 25 ml or 0.5 ml per kg, or the pH more than 2.5. Okay. So either you will be trying to empty the stomach by porokinetic agent, by either using of metoclopramide and domperidone in any patient. Even if there is some contraindication to metoclopramide, you can still give domperidone. This is one thing to have the stomach empty. The other thing is to stop the preparation of more acid. So that will be doing it with by PPI or H2 receptor antagonist. Okay. and this will not have any effect on the preformed acid. For that, you need to give the neutralize the acid with the non-particulate antacid. So, but whenever you are giving non-particulate antacid, you are increasing the volume. So you have to see what you want to do. Okay. So this is one thing. And another thing for aspiration prophylaxis that people do is pushing of NG, which is not a good way. Unless it is strongly indicated, you will not put NG, because it will reduce the gastroesophageal sphincter tone, and actually it will prone the patient for aspiration. Making the patient in ramp position is a way to relatively avoid it, because the intragastric pressure will be increased in that level, and then it has to go against gravity. So this is a sort of protection. Rapid sequence induction with cricoid pressure is a source of protection. And when you are giving dexamethasone, you have to think that you are giving dexamethasone, but dexamethasone also increase intragastric pressure. So it itself can cause aspiration. So you have to think in that way as well. So these are the things which you can do for the diagnosing the patient at risk. And if, for example, aspiration do occur, what will you do?
Sir, head down and suctioning, and then we'll intubate the patient if patient is intubated, and then we will do suctioning through the tube, also also we'll do bronchoscopy if there is any particulate is in the tube.
What else?
Yes,
when will you give antibiotic?
Sir, when there will be, we will not give antibiotic prophylactically, but if there is the element of, we will observe the patient in the ICU. If there is element of like infection, then we will give the antibiotics.
No. We are talking about aspiration. So if there is fecal matter aspiration, then
yes.
Because
or if the
acid is sterile, remember. So no need for antibiotic in that one. Okay.
Yes.
So this is one thing. And what about steroids or diuretics? There is no clear role. There is no role.
Yes. Okay? Controversial.
PEEP, you can use some PEEP. Okay.
Yes.
So this is a similar stratification. So we talked another complication which we have to anticipate and plan. Okay. So another important thing is multimodal analgesia. Okay. So which patient will be at risk for development of pain syndromes?
Sir, patient already having pain, patient going for multiple surgeries, patient, there is also genetic factors. Females are prone to have more pains, and also
again, patient-related factors, surgery-related factors.
Yes.
Okay.
Yes, patient-related factors are genetic, female patient having a low threshold for pain, a patient with anxiety, depression.
Anxiety, yes, anxiety, depression, taking any psychiatric medications, they will be at more risk. Okay, the patients with already having some new element of neuropathic pain like diabetes. Okay.
Yes.
And what are the surgeries which have more prone for development of chronic pain or neuropathic pain?
Yes, sir. The surgeries involving the more nerve resections, the surgeries with multiple incisions, and surgeries without.
No, this is not the way, Rabia. What are the surgeries which are prone for neuropathic pain or chronic post-operative pain? You will be surprised. Cesarean section. No. Cesarean section. Cesarean section. Inguinal hernia surgery. Mastectomy.
Sir, amputation is related. Thoracotomy, sir, inguinal hernia, sir, mastectomy, sir, it's that.
Okay, so these are the surgeries which are at more risk for chronic post-operative pain or neuropathic pain. Okay.
Yes, sir.
So you have to be thinking about this thing as well. That is it among that list? Okay, so you have to give even better analgesia. So we are actually short of time. I will try to cover what was in my mind. multimodal analgesia with paracetamol, NSAID, opioids, central regional anesthesia with either central neuraxial block with epidural or spinal, compartment blocks like paravertebral block, erector spinae block, TAP block, PEX block, subcostal block, or individual nerve blocks like upper limb or lower limb blocks, okay, or wound infiltration, wound catheter, okay, or some other things like this one, ketamine infusion, lidocaine infusion, okay, and this one, dexmedetomidine, okay, and in which I have missed to tell you preemptive and preemptive analgesia with NSAIDs, paracetamol, gabapentin to reduce the dose of opioids, perioperative opioid use, okay, and
preemptive regional anesthesia, like
sorry?
any preemptive regional anesthesia?
Yes, you in specific scenarios, like for example, if patient is having lung cancer, okay, and now patient is already having pain, and now patient is going, so you can place epidural to start with, and there are so many things you can tell in any surgery in which you can control the preoperative start. This will be part of it, okay. So you will be making a plan, and you will be considering the patient condition. According to that, you will be usually any involvement of kidneys, any involvement of liver, any involvement of respiratory system or neurological system. On the basis of those things, you will be chalking out, like you will be not using active metabolites if there is renal failure. If the drugs which are metabolized by liver, you will try to use the medicines which are having less metabolism. If there is bleeding risk, you will avoid NSAID. So things like that. But it shouldn't be in your mind whenever they will asking you about the, even if they will not ask you, but you have to tell, okay. So multimodal analgesia is the most important component of the anesthesia planning, and it will be starting from the level of surgery and level of NCN and the length of the NCN. So that's how much important is to plan, okay. So this is one thing. Then blood conservative strategies we have discussed in detail. Actually will not be, I will just try to enumerate the rest of the thing, all the factors which we can do to decrease the blood loss or decrease the blood transfusion. So this is called as blood conservative strategies, starting from preoperative anemia correction by IV iron, oral iron, dietary, ruling out the cause, and then you can store the blood, and then you can intraoperatively, you can choose a minimum invasive surgery. You can have a use of multimodal analgesia to decrease the stress response, and then you can have cell salvage. You can have normovolemic or hypervolemic hemodilution, okay. You can have use of tourniquet. You can have positional strategies. You can have this tranexamic acid. So these are the things, hypotensive anesthesia, okay, antifibrinolytic, as I told you. So these are the things which related to blood conservative strategies. Then another component is the fluid management, okay. So fluid management is very important. We have discussed multiple times in our recent days the same principle, according to the fluid status, according to the special electrolyte or a special crystalloid versus colloids, any specific condition if you want to give something or don't want to give something. One very important thing we have missed is airway risk, okay. So airway management plan is very important. You have to chalk out what are the factors for difficult mask ventilation, difficult intubation, and difficult laryngoscopy and difficult intubation. These are component of difficult airway. So you will be chalking out, and you will be planning accordingly. Use of bougies, or use of difficult LMAs, or fiber optic, or different size of blades, or video laryngoscope. These are the things, preparation for tracheostomy, or like these are the things which you will be considering, chalking out, and then anticipate. So this is one of the major component of preoperative anesthesia planning. And then like we do in every patient we have done, and the people who are in touch with us know that how we target. So in a induction agent planning, according to all the things which we have discussed, which patient it is better to use propofol, which patient better to use ketamine, which patient better to use etomidate. You should have a reason and not to reason for using it and reason not for using the others. Similarly, muscle relaxant. Similarly, the stress, that there will be patients who will be at exaggerated response of the laryngoscopy. So do you have to chalk out the patients? Usually are patient with head injury, patient with hypertension, or any other kind of preeclampsia, okay, or patient who are at risk of collapse at the time of induction. So in that case, you will be choosing the agent accordingly. Similarly, inhalational agents. Similarly, what else? So we have almost muscle relaxant according to the metabolism. So I have tried to give you an insight. A few things are still left. Like in which patients you will be planning HDU ICU. You should be very clear. Any patient having any problem in which you need meticulous care related to any organ system, that will be need of opioid, need of inotrope vasopressors, need for post-operative ventilatory support, need for any critical incidents which can occur in post-operative period. In that case, you will be arranging ICU or HDU. Okay, this is the reason. And then you will be chalking out which patients are suitable for day surgery. They can be asking you this thing. So for do's, you will be thinking about don'ts. And when you will not be doing the patient as day surgery. So that will be specific list related to patient surgery and anesthesia use, that you can do it or not. Like you will be not using prolonged anesthesia, prolonged regional blocks, prolonged like anything which has any risk of post-operative complications, you will not do it as day surgery. Okay. And then extubation at deep, extubation awake. So similar response which you did for the intubation response by blunting it, chalking it out and blunting it with the depth of anesthesia, with opioid, with beta blocker. Similar thing you will be doing at the end. If you are doing deep extubation, you have to make sure, because the patient will be at risk of aspiration. Okay. So anything important thing use?
Sir,
yes.
Management of post-operative complications regarding any particular patient.
Any particular patient. And when we were talking about blood conservative strategies, we have to chalk out another risk. One risk is bleeding risk versus thrombosis risk. Bleeding risk versus thrombosis risk. Because if you have a patient at high risk of thrombosis, like patient with atrial fibrillation, patient with valvular heart disease, patient with valvular mechanical valves, okay, or very obese patient who have the smoker, immobile patient, orthopedic procedures. Like there are so many things which are related to this thrombosis risk. There will be some factors in the patient, surgery and anesthesia, which will be leading the patient for the embolism. So you have to outweigh risk versus thrombosis risk versus bleeding risk. If there is more risk of bleeding, you will try to bridge. If there is more risk of thrombosis, if there is more risk of thrombosis, you will bridge. You will bridge the anticoagulants or antiplatelets the patient is taking. And if there is a high risk of bleeding, you will, and there is less thrombosis risk, you can stop according to the scenario. Okay. So either you will bridge, either you will stop, or you will continue as per the maximum time as with the bridging. So I think I have tried to cover this very important topic, which can help you in answering your questions in a better way. Okay. And main messages which I want to give you is that please try to classify rather than starting without any order. If you just chalk in your mind patient related factor, anesthesia related factor, surgeon related factor, it is high chance that you will not forget, but don't overdo. And you can also divide it in preoperative, intraoperative, post-operative. But again, the same message which I have just told you. Okay, so I hope you learned something. Okay, and if anyone wants to ask, because please, this thing, keep in your mind for any patient. Just make your mind tuned from head to toe in the similar way. Okay, there are some things which we might have missed related to head injury, related. These are specific things, but usually the pressures, usually the myocardial oxygen demand supply ratio, usually the organ blood flow. Okay, organ blood flow, maintenance of the vital organ blood flow, maintenance of the pressures like intraocular pressure, this one, ICP, IOP, abdominal compartment pressures, and the vital organs like brain, heart, liver, kidneys. Okay, so and again, my and Atik Bhai's favorite, my best friends, avoidance of hypoxia, hypercarbia, acidosis, maintenance of normovolemia, normothermia, normotension, normoxia. Okay, electrolyte imbalance, sinus rhythm, maintenance of cardiac filling pressures, right heart filling pressure, left heart filling pressures. If you forget, if you don't know even, then if you use these words, these are the targets which you want in any patient. Okay, so similar same factors are for pulmonary hypertension, similar factors are for cardiac stress, and similar factors are needed to me now because I am exhausted. Okay.
Sir, one thing I want to ask, can you please share that file of this
anesthesia plan?
I know you will kill me after that, but please.
Okay, so I will try to share this file, and actually I have tried to compile it in whatever way I could. Okay, just give me a second. I will try to show it. Actually, this is the thing which once upon a time I was not able to recall even, and I remember the day. And okay, so this is the file which Rabia was talking about, and I don't remember how many times I have sent this file. This is some points related to history, and this will be helping in anything, any managing any patient. Okay, and then you will find some factors about the history, examination. Okay, and usually this is a history of presenting associated symptoms, treatment and its compliance, aggravating and relieving factor, hospital admission. This is related to the history, presenting complaint. That can be pain, that can be bleeding, that can be cough, that can be anything. So the same thing visibly there, associated symptoms, treatment and its compliant, aggravating and relieving factor. This was related to the examination. There is no time for too much details, but I will just try to chalk out that you should be knowing the vitals, and you should be knowing the height, weight, blood group. And I have chalked out like whatever possible for me. There is always, because there is margin of improvement. So that's what we discussed today: patient demographics, medical, surgical, anesthetic history. If you have any history, that will be highlighted. Comorbidities, when to cancel or proceed, whether on which factors you will cancel the surgery or which factors you will proceed. Okay, if you want to cancel, why you want to cancel, and what optimization you need, investigation, what you want, and there should be reason. Actually, we discussed about ECG. Similarly, you should be knowing why you want to see CBC to see the hemoglobin, to see the platelets, to see the WBC, to see the blood profile. Then electrolytes, any condition in which there is expected change in sodium, potassium, calcium, you just chalk it out, and you can say use of diuretics, any clinical condition in which there is disturbance in it. Any patient having any drugs patient is taking which can damage the liver, you will do the liver function test. Any patient who are at risk of perioperative renal dysfunction, you should have a baseline renal or renal function test, or you will see any risk factors which are related to renal risk in that scenario. Okay. So medication history, usually we continue all the medications except oral hypoglycemics, or if patient is taking multiple antihypertensive agents. Otherwise, antiplatelet anticoagulants, you have to optimize accordingly. These are the sums of the scores which you should be using as ASA, METS, New York Heart Association classification, Canadian classification, active cardiac condition, clinical risk factors, pulmonary risk factors, cerebral risk factors, renal risk by Akin or Rifle, creatinine clearance for CRF, childpox. Actually, we forgot to discuss liver, but actually liver, majority of the things are the common. So liver usual symptoms will be related to like abdominal symptoms or vomiting, nausea, vomiting, abdominal pain, or bleeding from upper GI bleed or lower GI bleed usually. Okay. And we classify, 2 days ago we discussed liver. So if someone has any question, they can. Spinal cord risk. Spinal cord risk will be any surgery with hypotension or clamping. There will be risk of spinal cord injury, as we discussed for kidneys. Almost similarly for spinal cord. And the same principle will be used here. They will be doing evoke potentials to see it. Okay, for men to see any problem in the spinal cord. PON risk factor we discussed. Aspiration risk, yes. Hypothermia we did not discuss. Hypothermia, how to predict, like premature babies or babies who have less lipid and fat, and they don't have the thermogenesis normal thermogenesis mechanism. Okay, and ambient temperature and cold fluids and blood transfusions and role of use of regional anesthesia. So these are all the factors, or some other, even general anesthesia gradually decrease the temperature. So you have to maintain with the temperature, with the ambient temperature, warm fluids, warming blankets, bear hugger, what else? Warm humidified air. Okay. So yes, spine examination. Spine, any condition in which you are expecting any kyphoid scoliosis, in which you can face problem in the spine. And yes, IV cannulation. Okay. So this is also part of your anesthesia planning. Any patient, old age patient, pediatric patient, Bablu patient, Bablu patient.
Yes.
Okay. So Bablu patient looks very like, but for anesthetist, actually, sorry, for the other, Bablu patient means chubby patient. Okay. So the patient who looks chubby, they are looking very beautiful, but it's a nightmare for the anesthetist actually. Okay. So multidisciplinary team approach. For every patient, you have to try to accommodate different teams. You should be knowing different teams. Okay. And we did not discuss about pre-medication. Pre-medication related to anxiety, pre-medication related to secretion, pre-medication related to management of insulin. This is also coming in the pre-med. We actually discussed once upon a time, we discussed about pre-medication. So, okay. And pre-medication for Vanita, because she is my colleague. Vanita, pre-medication is not the one which is being used in our hospital. Pre-medicate's not, it's pre-operative evaluation rather than pre-medication. But I don't know why our hospitals say doing the pre-operative assessment as pre-medication. It's wrong, and it's going like that. We cannot do anything. Okay. And then we will be.
Yeah, I get confused with that. They say go for pre-medication. So I said what?
Yes. So now you are immune. Okay. So this is pre-medication means something else. Okay.
Yeah, before surgery, what drugs you give is pre-medication.
Yes. Pre-medication can be anything. Okay. Preemptive analgesia is also pre-medication. Secretion decrease is also pre-medication. Okay. So there are so many things.
Anticholinergic, sedatives, and or whatever.
Yes. Okay. So one important thing I missed is the point of care testing being used in the operation theater. You should be thinking about monitoring plan. Okay. In addition to standard 1, standard 2, what additional monitoring you need? So this should be also part of your planning. Any patient, for every surgery you think, and in addition to standard 1 and standard 2, do you need any monitoring? Okay. So that will be the special monitoring you will be needing. For example, intravasive blood pressure monitoring, CVP monitoring, cardiac output monitoring, neuro monitoring, use of INR, this one, point of care, INR or ACT or thromboelastography of the rotum, okay, or blood sugar monitoring, ketones monitoring, urinary dipstick tests. So there are so many things which you can do. BIS monitoring in special patients, okay. And specialized ECG leads, okay. Specialized ECG leads, the CM5 or CB5 leads, which we use in at-risk, high-risk patients, okay. Or use of T. It is actually theoretical. Nobody use it practically, except for very specialized centers, but you should be knowing about it. Then any specific monitoring or in a specific test which is being used or needed, and anticipated perioperative complications. We discussed a number of them today, like air embolism, pulmonary embolism, bone cement, tourniquet, position related, whatever we said, okay. And maintenance plan with which blood loss, this I think we all discussed, okay. So these are my best friends: normoxia, normocarbia, normotension, normovolemia, avoid sympathetic stimulation and stress, maintain myocardial oxygen demand supply ratio, maintain sinus rhythm, maintain SVR, maintain preload and afterload, maintain right and left sided cardiac filling pressures, okay, multimodal analgesia, and maintain organ perfusion pressure, okay. So I think that's what you wanted, Rabia.
Sir, please share it in the group so that whatever you have explained should be imprinted.
Yes.
Should be fixed.
Actually, it is in the main link in the topic wise questions. You will find it. I will send. Okay, no problem. Okay, everybody. So now my perfusion pressures are decreased everywhere in my body. So I need to go. Okay. Okay, Deep bhai.
Thank you so much.
Okay, sir.
Okay, bye bye.